Janae Sharp, founder of the Sharp Index, and I'm thrilled to sit down today with Jonathan DePierro. And he's an author, a clinical psychologist, an expert on trauma and on resilience. So I have a million questions for you today. I'd love if you could introduce yourself to everyone here.
So I'm Jonathan DePierro. I'm a clinical psychologist, as you said. I'm an associate professor at the Mount Sinai School of Medicine in New York City, where I run a center called the Center for Stress, Resilience, and Personal Growth. So a lot in that long name, where we take care of healthcare workers. We teach them skills to build resilience and improve their mental health. And we also provide free evidence-based treatment to support their mental health. So things like psychotherapy. We do that quite a lot. And we do research as well.
I love that. We were speaking to some medical schools and some leaders who say that that's a huge need, especially for like newer learners or newer physicians, that like everybody wants it. So can you tell us a little bit more about that? Like, does everybody go? Like, is it just part of the school? Is this system-wide, everyone in New York? What does that look like?
Yeah, so the Mount Sinai Health System, of which the Icahn School of Medicine is part, it's our medical school. The Mount Sinai Health System is a huge system sprawled across New York City and Long Island, with 7 or 8 different hospitals, the medical school, lots of ambulatory practices, and about 45,000 total employees. We have the most medical residents of any program in the country. The most are at Mount Sinai in the Mount Sinai Health System. We have a lot of physicians, a lot of nurses, but I think the other thing that gets overlooked is that in a hospital, lots of other people work there. Security staff, cafeteria, food service workers, environmental service workers, administrative staff, researchers. So a lot of literature, a lot of news stories, rightly so, about nurses and doctors, but our center is exclusively for literally anyone who works or learns in the Mount Sinai Health System of any role. So there's no entry criteria that you have to have MD or RN after your name.
That's nice. Also, it's internal though. So do some people resist like, do you guys have a lot of people who want to go? Or I know some people wouldn't want to get health, mental health support from their employer.
Yeah, so that's a good point. We do a lot of different things. So one of the things that we do, which is not therapy and not a treatment service, is that we provide educational workshops to build mental health awareness, to help teams grow together. And those are available to any healthcare worker. We actually go to them. So we've been through federal funding from the Lorna Breen Act. We've been going to ICUs and emergency departments across the health system and teaching about mental health and about different ways that teams can grow and be more resilient together at the morning and evening huddles that they already have in these units. So we get people together. Really, all they have to do is not walk away for 5 or 10 minutes and talk about these topics, and not requiring them to come to a big workshop that's 45 minutes or an hour outside their job hours. So going to them with that education has been really helpful. And that's really for anyone within the system, and for leaders especially who have been doing particular trainings. When it comes to mental health treatment, it's true, it is in high demand. One of our surveys show that 50% of our workforce, so half of our workforce, said they at some point in the past year they thought about wanting to see a therapist. So you can extrapolate 45,000 people, that's 20,000 people.
That's a lot of people.
That's a lot of people. One of the things that we know is that about a third of those folks actually got care or connected to care.
Mm-hmm.
All sorts of different barriers. Some people have confidentiality concerns. Some people don't know that we exist as an opportunity for them, or don't know that we exist as the service. So we have a marketing strategy. We have work to do on the marketing end, and I can talk to you about that later. Some people are concerned about documentation in their chart because we're part of our psychiatry department. They're afraid their supervisors or peers are going to find out.
Right.
But I think those are not insurmountable barriers, because what we do is we provide a lot of education about what it means to be in mental health care, how we document, who we tell, which is no one.
Right.
Literally, like, who has the time to tell their supervisors? Like, and also that would mean we get fired, and I'd lose my psychology license if I
Right.
spread the word about somebody seeking care inappropriately. They have all of these protections that a patient in the hospital has and more. We have additional privacy protections on their medical charts called break the glass. We have to put in the password twice. It's even more burdensome to access the notes, and
You
it's
get
all
more
logged.
clicks.
More clicks, right? And everything is logged. All the access in these charts is audited. So there are all these protections in place, and oftentimes providing that education is enough for people to feel comfortable coming in. Also, having a friend or having a mentor or supervisor who's sought care at our center and had a positive experience can be helpful in lowering those barriers or lowering that internal stigma. So word of mouth has been our
Right.
most important referral source.
Mm-hmm.
Getting a testimonial, we've had panel discussions about mental health where very high profile folks within the institution have talked about their own mental health challenges and how treatment writ large has been helpful for them, not even specifically in the center, but in general. So testimonials are really helpful. And there are folks who will say, no, never, I will not get care within our health system. But we also can do some work to help connect them to people on the outside so they don't need to do that investigative work on their own. I
Right.
even did that twice today, helped people connect to care
Oh, that's
outside.
nice.
So that's something that we can do as well. But we really encourage people to come to us in part because we're strongly evidence-based. We all provide the same intervention, cognitive therapy. We have some medication management, and people can readily access care. There's not a wait list. They don't have to wait months and years to see a therapist. It's immediate. And if they call our phone number at our center, if they're a Mount Sinai healthcare worker, they get a human being on the phone. They don't
Hmm.
get a phone tree or an AI bot. They get a human being. And I think a lot of them are surprised that they get a human being and get an appointment and walk away from that phone call with an appointment.
Yeah. I think people are surprised. I also like what you're saying about education. In our work, we found that clinicians and physicians specifically, even if they want to have assistance or need it, um, they're reticent to publicly do that, but they'll often participate in group support or
Mm-hmm.
educational opportunities. And sometimes you have the same efficacy, like you have the same outcomes. Like you're still there in group therapy, even if you're saying you're there to support other
Mm-hmm.
people. Like you can still benefit without feeling like you came out and outed yourself. So it's not quite like AA. I I'm interested from your perspective when you do those rounds. I don't know if you've been on that or if you've gotten
Mm-hmm.
feedback. Like, what are the questions or the concerns right now for mental health? Like, what do you hear? What are the questions you regularly get?
So I've done some of those rounds in the ICU in the emergency department. I remember I did one of the first ones, and because there were so many people there, I had to stand on a milk crate. So which was quite a scene. I wish that somebody took a photo of that because I was balanced because I didn't have very good balance at the time. Balanced on this milk crate, talking about mental health, um, which was something new that we were doing in this setting. Um, I think in terms of the questions people get, like, is this really confidential, this care that we provide? Yes. Um, and in terms of the concerns that people share, and I think in the pandemic, we did see some instances, not all, but some instances of PTSD
Mhm.
from the pandemic and what they saw, healthcare workers on the front lines, um, seeing death, seeing very difficult, morally complicated situations, feeling inadequate or inept to save the lives of their patients, feeling they're seeing and thinking realistically that their lives were in danger themselves when they come to work. So we did see some post-traumatic stress disorder, and we treated that. Um, and we do see PTSD and depression resulting from workplace violence incidents now, and there's been
Mhm.
a rise in workplace violence, as you know. But I think there's a general exhaustion. I think just general misery and unhappiness is what we deal with. And I think it just reflects the population at large. There's special things about healthcare workers and the stress that they undergo and the things that they experience, and they're human beings.
Right.
And they have the same concerns people in their lives dying, divorce, life challenges with their children. They have those concerns too. And because we have no admission criteria in terms of it needing to be a workplace challenge, people can come in for any manner of concerns. So it's not that we only hear people are burnt out, people are exhausted. People are coming to care and support, or even attending a workshop that's not treatment for a variety of reasons, including because we came to them and let them know that it exists.
I like that. You're treating the whole person, not just like
Yes.
one condition. There are a few things that you just said that I wanted to talk about. One is related to some of your work that I watched about talking about traumatic memories and how memories are malleable. And I've I've heard a lot about that, especially in relation to grief and loss, because after loss, there's a period where you're intensely grieving, but also where you have different brain plasticity, you have different capacity. So I was really interested in your work in that space. Like, what do you mean by that, by traumatic memories being malleable? Or even when you're talking about
Mm.
PTSD, like, what does that mean? Like, are we now in a space where the people who had suffered from PTSD during the pandemic, they're healing or they're changing their memories? Like, what does that look like?
Yeah, so that's a big question,
Yeah, it's like
and
eight
I could talk
questions in
for
one.
it's eight
Sorry.
questions. I can talk about this for quite a while, but very basically, people used to think about memory, and maybe some people still do, as aspects of an event that kind of are set in stone in your mind that never change. And the reality is that every time we bring up a memory, every time we recall a memory and tell a story, it can be put back in our brain a little bit different. So, a common funny example of this is the stories that are told around the dining room table on holidays. You might hear a relative one year tell a story, and the next year it's a little bit different. There's a little elaboration that somebody added, and then that becomes part of the story, and then somebody
Or
else adds
in my
something.
family, your parent remembers what happened, but not which kid did it.
Yeah. And the story gets retold differently every year with different aspects to it. It's not exactly the same every year. It is elaborated, different, tweaked, corrected, and traumatic memories can work the same way. Some of the things that keep traumatic memories um, upsetting and difficult to connect to are the fear that come along with it. Uh, when somebody goes through something like the pandemic or car accident or traumatic loss, there's a lot of really strong negative emotions: fear, sadness, anxiety, panic, that get stored along with the facts and sensory aspects of the situation. Another thing that makes it really traumatic memories really challenging is self-blame and what we tell ourselves about the situation. So an example of this is being in a car accident and walking away thinking this was all my fault. I should have been paying attention more. I was a little bit too sleepy, or I should have been more careful in how I was driving, how fast. I shouldn't even gone out in the first place. How stupid am I? What we tell ourselves about the situation really matters. And the avoidance aspect to traumatic memories. We don't like talking about it. We don't like thinking about it. So
I
we
feel
try to
like we
put it
need to
away in a
pause here
box.
because for all
Mhm.
the people in my life that have been like, let's not talk about it, keep going.
Yeah.
So you're telling me avoidance doesn't work?
Avoidance doesn't really work. It's a short-term survival strategy, but when someone has had a traumatic memory, and it really has to be at their own time, often sometimes with a therapist accompanying them in this journey, but talking through the traumatic memory, telling a story about it, helps make sense of it. And when people heal from traumatic memories, they a oftentimes are helped by telling a story about what happened from A to Z to really help them um, avoid avoiding, to actually directly confront the negative emotions. Every time you tell this the trauma narrative, you have the negative emotions come up and you get through the story, it gets put back in the brain with a little bit less intense fear, a little bit less intense sadness. You re-remember it with a lower intensity of emotion. It becomes a little bit less overwhelming, not entirely benign, but a little bit less overwhelming, easier to confront. It becomes more clearly a part of your life versus your entire life. But I think that the challenging part is that traumatic memories are just so overwhelmingly upsetting. Um, but a lot of successful treatments help people tell their story, to tolerate the waves of emotion, and to challenge the blame thoughts that they might have. So someone after an assault might blame themselves. Someone after a patient dies from a complication or from COVID might say, it was all my fault, just my fault, on my shoulders entirely as this healthcare worker in a busy COVID unit in the midst of the pandemic. It was my fault. That's why my patient died. It was my fault. That doesn't help. It doesn't help the fear. It actually drives the fear and drives the avoidance. So in trauma recovery, you learn to challenge the reality basis of that thought. Is that a
Mm-hmm.
helpful or realistic thought? And as you tweak and change and mold that thought and help see it more realistically, it changes the way the memory gets put back in the brain. Because the aspects of the memory get stored with a different interpretation and a different set of emotions. So when you bring it up again, when you tell the story again, when you remember it, it is remembered differently. The
Mm-hmm.
visceral experience of that memory is different.
That's interesting.
Some
I've
people do
also,
this through art as well. They make sense
yeah,
of their experience through telling the story in art. And the next time they tell it, the next time they tell it again, it's different because of the work that they did.
I've also thought I like the idea of like working things through art. I've also thought sometimes that that's like a safety response when people take responsibility. When people are like, "Oh, I wish, I'm responsible for this." It's a way for them to try to ensure that it doesn't happen again. Um, it does create some super toxic and super
Mm-hmm.
horrible situations when you've dealt with like suicide loss or loss of a coworker or a loved one, because they just take that on
Mm-hmm.
and they try to do everything in their power to make sure it doesn't happen again or to kind of like punish themselves. So you're nominated for your innovation and like kind of meeting that need, like finding that space in between and building interventions. But I'd like to hear more about some of those practices that you've built. Like what's been the coolest thing you built?
Mm.
Because you're a builder, right?
Yes, as long as you don't give me power tools, because I'm probably unsafe with power tools. Um,
All right, we'll put someone else in charge of the construction.
the actual, yeah.
Yeah.
Um, I think the coolest thing that I helped build with a team, really 2 months into the pandemic, starting in April 2020, our dean, Dr. Dennis Charney, is a psychiatrist and a world expert in trauma and resilience and depression. He's our co-author on our book. Um,
I was
he
muted. Here's the book.
he got a team of us together early on in the pandemic and said, look, our healthcare workers are suffering. We need a new center to help take care of them and to help them get through this. And we had 2 months to plan it and open it.
So
So
you just whipped up a center in
we
2 months.
we
That's fine.
whipped it up, basically. We had a lot of help within the health system. We had a lot of resources made available to us, starting these workshops, hiring staff. There were donations that were made. There was philanthropy involved, which was very helpful. But to see it begin to blossom, to see workshops begin to be offered, to see in October of that year our our behavioral health service emerge, and now we've done 17,000 visits in 3.5 years.
That's
So
a
we
lot.
started offering this behavioral health care in October of 2020, and it's now May. We take care of a lot of people. We've taken care of probably closer to 2,000 healthcare workers at Mount Sinai and some of their adult dependents. And it was been, I think, one of the most rewarding experiences of my life to see people call, get an appointment, get care, and get better.
Right.
Like, I think it's going to sound very strange, but one of the best parts of my job is seeing patients for a short time and never seeing them again in a good way because they don't need to.
Mm-hmm.
I don't think of psychotherapy as a lifelong engagement. I kind of think about it as going to the orthopedic surgeon. You break a bone, they do surgery, you wear a cast, they take the cast off, you do some rehab, and you never see that person again, hopefully. We're there if you break another bone, or if you need, more rehab or different skills. But my goal is to have people walk on their own 2 feet.
Right. That's important that it's something that gives you the skills to live. Um, something that I thought about and some of the people from the nonprofit talked about when we were looking at your work was talking about that, but like a step further. Like we talk about resilience and our ability to bounce back and grow and thrive, but a lot of the stress is like it's from external sources.
Mhm.
Like if you have someone who's been through that very concentrated treatment and you put them back in like the most horrible situation, or like, back to never sleeping in their job or whatever, um, is it possible for them to still thrive, or do they end up in a cycle? How does that really work? Because sometimes if you look at it, I think of it this way. Um, like we've been through a lot of therapy because my kid's dad died. But no matter how much therapy we go to, he's still dead.
Mhm.
So like some of that has ongoing stress. And it's really confusing when people talk about loss and about that stuff for some people. Um, like, is it possible to create a healthier health system, or is this, just something where we're doomed to fail? And that's a big question again. I'm good at big questions.
So am I engaging in a futile effort because
I mean, I think it's a valid question, right? Like maybe this is a capitalism question, but like, you
maybe
know,
I should just, do something else and like herd sheep in Scotland, which is my backup plan dream.
is it? I don't think that's my backup, but like I do sometimes talk about like going and, living off the grid and developing circus skills,
Mhm.
if parenting doesn't work out.
I don't know about circus skills for me.
I don't have
Um,
any.
but I think this goes back to some of the educational work that we're doing. So one of the things that we noticed, and there are partners, you probably know Dr. Jonathan Ripp at Mount Sinai, who's our chief wellness officer.
Yeah.
We work with partners to affect system level change. It can sometimes feel like steering a big ship where it takes a while. Sometimes it can be surprisingly quick. Um, but that involves, for example, every new leader in our institution goes through an orientation run by our HR department, who we work with, called New Beginnings for Leaders. And as part of that orientation, in addition to all the institutional policies and procedures, they get an hour-long talk by our service on how to recognize signs of stress in their subordinates, in their employees, how to what are different stress reactions to look out for on the job. Something really bad happens, what are the different ways people respond,
How to not
and
be a
how to
jerk
have
when you respond.
yeah, that. Yes.
Yeah.
Yes. And right, how to have a conversation about what resources are available, how to express concern in a meaningful way, how to have a conversation without also checking your phone and checking your computer, giving someone your full attention. And it might seem strange, but these are skills that don't necessarily come along with the mantle of leadership. You may not learn these things along the way. Yes, you know how to do the job. You might have been promoted into the job, and sometimes they're called soft skills, which I think is ridiculous. Um, they are part of being a leader. They are an increasingly important and increasingly recognized part of being a leader. How to take care of the people that you work for, that who work for you and who you work for too. But um, that's increasingly important. And I think industries, organizations, health systems are seeing that is an increasingly important part of the work, that we take care of people who, take care of the employees. They can then become better, more productive employees, better team members in a healthcare setting. They take care of patients more effectively, safer, if everybody works together in a communicative way where they feel psychologically safe, where fear is minimized, punishments are minimized, those kinds of things. But leaders need to be educated about that.
Right.
And it's not because they're bad people. They might not have had very good mentors. They might not have had this
And
training
not
as
all of
part of
it's
their curriculum.
obvious. It's
Yeah.
not obvious. I
Um,
also think physicians also identify like lack of leadership opportunities and leadership
Mhm.
education as like a major source of burnout and stress. And they, relative to other leadership positions, have less experience in terms of just solid management training.
That's right.
Um, so,
Um, and a number of folks at our health system and at others say that they don't really know where to get a mentor,
right,
which can feel very, very isolating. And there's a lot of programs that have been put in place within our health system to build mentorship, to partner people up, to have small groups of, academics at the same faculty rank supporting each other, like making peer groups, those kinds of things. But we talk about resilience. It has to be a combination of system level change, system level drivers, which we have partners working on, and individual level supports.
right,
Because you're not entirely out, you're not entirely off the hook. You still have a responsibility to take care of yourself, to challenge your own negative thoughts, as much as the workplace has a responsibility to make sure that you're not going in and being re-traumatized.
right. I would say I'll take like the pizza party and system change. I'll take
Mm.
all of it. Like,
I do like free food, but I often say when I do resilience, like resilience themed talks, I put a slide up that says, with a picture of a pizza party that says, this is not the resilience I'm talking about.
yeah, but I'm always like, you haven't found good pizza. Like, like the real problem here is that they're
Mm.
not using good pizza, or, that they're trying to compete with each other at who's the best at yoga. They're not actually practicing, they're competing with each other to see who's the most flexible, which is fine too. It's just a
I, I'm, a,
different sense.
yeah, I'm personally a fan of like ice cream sundae parties.
Yeah. Like, and if my theory is that if the pizza is good enough, it will also meet that need. But we haven't found it yet. And you're in New York, so
Right, that's your pizza theory of burnout.
my pizza
Maybe the
theory of
pizza's
burn.
just not been good enough.
Also, my other theory is if they've convinced you to attack pizza parties and yoga, you're in a really dark place. Like that comes from a place of hurt.
Well, I do adore, you probably have seen him, Dr. Glaucom Flecken,
Yeah,
Will Flannery. His videos have been
he's hilarious.
amazing, and most of our healthcare workers just absolutely love them and look forward to sharing them.
Yeah, he's very relatable too.
Yeah.
And I like too that they talk about like the whole healthcare system. Like
Mhm.
it's a whole thing. Like it talks about insurance, in education. Like we don't always or even what you're saying to leadership, like we're not really training people or educating them based on what they're going to need,
Mhm.
um, which creates some stress. Um, but we should also talk about your book. Speaking of stress, I have not read the book yet, except I read the back. I read the last chapter. So I'd love for you to tell people, since we're going to read this for book club in a bit, um, what should they keep in mind when they're reading this? Like, what should you know before going in?
So this is the third edition of Resilience, the Science of Mastering Life's Greatest Challenges. It came out in September of last year, so September of 2023. And it's really a book about resilience and the different facets and aspects of resilience for the public. So we talk a little bit about science. We took out a lot of jargon and from prior editions. We made it very accessible and fun to read. We included real life examples of people who've been through some difficult situations, everyday people, and then some examples from POWs, prisoners of war from Vietnam, from special forces folks, put in extraordinary situations, and how they used these skills and these aspects of resilience to get themselves through psychologically. And oftentimes it meant getting themselves through with each other, not just like no man is an island. They were with people often in these situations, all working together. And so I think that's an important part too. And each chapter ends with suggestions, evidence-based suggestions. So not um, something I made up, but something that the research really shows are effective ways of building yourself up in these key areas, and even activities that you can do to say build your optimism or help you reframe challenges or connect to social supports, start a self-care routine, although I don't like the word self-care as much as I don't like the word burnout.
I hate that word.
Yeah, connect to meaning and purpose, connect to altruism. The thing we think about resilience less so as a personality trait and more as a set of attributes that can be built up like muscles.
That's interesting. Like it's something you practice.
Yes, for
I'm also
sure. It
someone
has to
who
be.
I think of myself as pretty resilient. And I also hate the phrase. So like when I first saw the title of the book, I was like, I don't want to. Like, I don't want it. And also you do some work with like, you know, veterans and people who've been through warfare. And when I was reading about your work, it was interesting to see that intersection where we're talking about
Mhm.
workplace violence, we're talking about people who have, fought to defend us and people who have gone to war and then healthcare workers. Um, what's that like? Like it seems intense, and also when you're talking about like research-based stuff, like do you guys do research with that? Like, you know, tell me
A,
more about that.
a lot. So, um, after 9/11, even that day of September 11th, mental health clinicians and medical staff went down to ground zero, went down to the armory, went to other places to begin to provide support, provide medical services, provide psychiatric and emotional support services. And out of that, through the work of our colleague Craig Katz, became ultimately the World Trade Center Health Program. So there was an act of Congress, kind of like the Lorna Breen Foundation, Lorna Breen Act.
Yeah.
There is what's called the Zadroga Bill. Eventually, like 10 years after 9/11, there was a Zadroga Bill that funded permanently health care for 9/11 responders and mental health care for 9/11 responders and survivors. And Sinai has been at the forefront of that. We were some of the first folks to go down. And for, my goodness, 23 years, we've been taking care of 9/11 responders. I think something like 40,000 responders get care at Mount Sinai. They go every year for
Oh,
physical.
wow.
That's free. They get cancer related care. They get respiratory related care at Mount Sinai, GI problems, and they get mental health care for free, funded through this act of Congress. And because they come in so frequently, and because there was measurements put in place very early on, we have amazing data, and that's been published on about how they've done medically, but how they've done emotionally as well. So one of the things that we know from tens of thousands of first responders, you never get like samples like that. It's very rare to have
No.
just that
Yeah.
those numbers in research articles. Is that social support was incredibly protective. So those first responders who said that they had support at the time in their families or in their friend group or in their police precinct, and immediately afterwards, that social support was incredibly protective. It lowered their risk over a decade or more of developing PTSD, depression, and anxiety and alcohol use.
That's
So
amazing.
that psychological attribute, something about their environment and their resilience at the time, which can be built up. We know, if we know social support is important, well, it turns out we should like build that up for people we know we're going to be deploying to difficult situations, and we should be watching out for that as they're doing their work. Um, Incredibly important and protective. We know from other studies with veterans, our colleague Dr. Rob Pietrzak at Yale studies retired veterans,
Hmm.
that actively coping, so reframing their difficult situations, altruism, facing fears, um, giving social support to others, like being in somebody else's corner, supporting somebody else, and a sense of meaning and purpose are all also protective factors. So all of this research, and we do brain imaging studies as well. There's a lot of that kind of work happening at Mount Sinai and other places. Um, all of that work has given us a sort of toolbox or toolkit of what resilience looks like.
Hmm.
So when I
And
say it's research based, it's based in 20 plus years of basic biological research of what goes on in people's brains. And also, we have neuroscientists at Sinai that study resilience in rodents. They expose them to like bullying situations by a bigger, meaner rodent, and they see what happens. And we learn a lot about resilience through these analog studies of looking at models of human situations in mice and rats.
Well, that's fascinating. I also have one kid, by the way, who always stands up to bullies. You know, sometimes, sometimes he doesn't beat him, but he's resilient, like, or,
Yeah.
he's just always sticking up for people. So I always think of that. That's good to know with the book. I'm gonna read it. I'm excited. And I also didn't know that about like all the research after 9/11. I have a friend who was there, Dirk Stanley, providing medical support for people. And I'm glad that they got that support. Also, it makes the Lorna Breen Act pretty impressive, like the timeline. Like the
Yeah.
9/11 one took so long.
It took so long. There was private foundation funding for a while, but it took a while for there to be an act of Congress. It took a lot of research, a lot of advocacy. And I hate to say this, but maybe one of the silver linings of the pandemic is that there was work that came before that showed just how impactful events like this could be. So it was easier to point to big local examples, like with a healthcare worker tragic, death by suicide or lost to suicide, but also to the decades of research that came before to show that when things of this scale happen, there's going to be psychological impact. There's going to be people that are really in need. There's going to be healthcare disparities that are going to be really important to be talking about, and the existing infrastructure just can't sustain it.
Right.
One of the first papers that we wrote during the pandemic was an overview. It was looking at pandemic response plans across the world. So pandemic happens, you think about like, okay, we need certain kinds of medical equipment. We need drugs. We need personal protective equipment. We need body bags. We need temporary morgues and hospitals and tents. We need personnel. We need to train people. No, almost no country's pandemic response plan had a mental health component.
Oh, really? That's
Yeah, so
terrible.
that was the paper basically saying, hey, you need to pay attention to this
Yeah.
because it's not like, yes, there's going to be bodies and casualties and a lot of medical need, and there's going to be a real psychological toll and impact, and that needs to be part of your plan right up front. Otherwise, you're going to be trying to build the plane and fly it.
Right. Which is how a lot of people describe what they did during the
Yeah,
pandemic.
right. We
You
don't
know?
want that to happen again.
No, because not everybody can do that. Also, I have two more questions. One, right now we're talking about mental health and like global mental health. There's been a lot of talk now about, mental health isn't, we're not all doing so great right now. Um, and it's interesting to kind of think about why that would be. I mean, people have a lot of things to talk about. I was wondering if what's your take on that? Like um I mean, and I don't know if you want to specifically talk about healthcare workers or, or something else. Like what's going on? Is this because we didn't have a plan? We didn't have the support? Like
Yeah,
are
so
are things
yeah,
actually worse? Or is that,
I think there's certainly a perception that things are worse these days, these years than prior years. I also think there are things like, for example, like things like social media, and there's mixed evidence, but things like social media can create a false sense of closeness.
Mhm.
Oh, like I'm connected to this person on Facebook. I have all these like social media friends. There's emotional attachment, but it's generally not a deep supportive relationship. And it can feel really isolating. And I think there's a strong sense of loneliness that's swept across the population, specifically in older adults and teenagers who tend to be really struggling right now, a sense of disconnection. There's a lot of social pressures around um, fitting in and around academics, increasing pressures around academics and the emphasis on that, and it has been tough for this generation. And there's been big things that we've been through, right? There's global conflict. There's news of global conflict, which makes it seem ever present and accessible. There's videos online of horrible atrocities that people can access and watch at any time, anywhere. and it can take a toll. It can wear down on people. It can seem like the world is falling apart. It may not be, but it can certainly seem like it. And there's a lot of felt uncertainty.
Right. That's interesting because like social media does allow people to access like connections,
Mhm.
but they aren't always as deep as,
Mhm.
the loneliness is still there, even with all
Yeah.
that.
And
Um,
I think there has been a disconnection from a sense of meaning and purpose.
what do you
A
mean?
lot of people who are surveyed say that they're just in like population surveys say that they're lonely and don't really feel a real sense of meaning and purpose in their lives.
Hmm.
And those are real challenges. And I think that's something that really needs to be looked at: loneliness and connecting to a sense of meaning. And meaning has to be made; it can't be given. So people have to find things that give them a sense of meaning.
I like that. Like you can't force it. Meaning has to be made, not given. Also to what you were saying with, 9/11 versus now, like we have the Surgeon General talking about
Mhm.
loneliness. Like I think our foundation for mental health has come a long way. And I talked to a leader once who said you have to know where you're at in the
Yeah,
innovation thing. Like when we started talking to people about physician and healthcare worker mental health in 2018, the conversations were vastly different and we still had more blame than we have now. And you have to kind of know where you're at. Like, and there have been decades of research and of work about how important it is. And I think for me, it's hopeful, like that things will continue along like a healthier path.
yeah. So that raises a good point, and I think it just to put a fine point on it. You know this as well as I do. You know this personally that healthcare workers were struggling well before the pandemic.
Yeah.
It was not very well documented. It was taken to be part of the job that they should just suck up. But the pandemic really put a spotlight on the well-being of healthcare workers. It exposed vulnerabilities that were already there. It exposed a need that had been brewing for decades or 100 years, maybe. And things came out of it that helped people not just because of what they went through during the pandemic, but helped people deal with things that happened years before and helped a
Right.
newer generation of healthcare workers who didn't experience, patient care during that time. Same true for 9/11. I think my impression, this is anecdotal, is that 9/11 was a catalyst event that was a shared social trauma, and people came to care for 9/11 related concerns, and in the process dealt with stuff that happened before 9/11. It's
Right.
like they brought all of that as a person into therapy, and it gave them a needed, necessary, and socially acceptable reason to seek care. Oh, this big thing happened.
Oh
It's okay for me
yeah,
to seek care.
that actually makes a ton
Like
of
the
sense.
pandemic happened. It's okay. Like pandemic happened. It's okay for me to seek care. It overrides my stigma because everyone agrees that this is a horrible thing. And it was. Um, but for example, for 9/11, law enforcement officers were dying by suicide before 9/11.
Hmm.
They were struggling with PTSD and anxiety before 9/11. But events like this help put a spotlight on this need that existed beforehand. And, World Trade Center program, NYPD programs, other healthcare workers across the country, even federal agencies have begun to look at this much more seriously. We're involved in some of these conversations, which makes us feel really, it feels really good to be part of these conversations, to be helping people even outside the health system, our health system, having conversations at the governmental level,
Right.
or with local agencies or with nonprofits, taking what we've learned about resilience in this setting and exporting it to other settings that are similar.
Right. And I like that. Like it's an opportunity also for like to go back and heal the things that you didn't think you
Mhm.
could seek healing for.
Yeah,
So my last question, since we're running out of time, is what are you going to build next? Like what are you looking forward to? I didn't prep you with this one, so it is my shortest question.
that's a really fun question to answer because I can answer a couple of different ways. One, that comes to mind is that we developed a mobile app platform to train around resilience. So we have activities, different kinds of educational content. We have a scale that we developed to measure resilience. So, like, how much are you using these
So we
different
can
resilience
test
factors?
ourselves? Like, can we,
Yes, you can.
so I
Yes.
could, can we do, is there a leaderboard? You could build it. This is an
The
idea.
most resilient person.
Yeah.
Um, no, there's no leaderboard, but that's a good idea. Um, but we have a mobile app platform that we're doing a clinical trial with to see how it can help people build resilience in their own lives and build teams resilience. We're adapting that outside of the healthcare setting to help community health workers in New York City through a partnership from an NIH grant, which is very exciting. We're thinking about ways to use this app in other settings, like with law enforcement populations where there's ongoing, like healthcare, there's ongoing stress. That's one similarity.
Hmm.
The stress continues. There's new events that pop up.
The
And I
horrors
think
persist, but so
the
do we.
horrors persist, right? And so do
Right.
we. That's exciting for me. And I think the most exciting thing is opportunities to advance our definition of what we consider to be resilience, our understanding the biology of this, and to take what we've learned from big tragedies like 9/11 and the pandemic, what we've learned from taking care of healthcare workers, and applying that research to other people in other settings where they're stressed. Because there are common factors. There's actually more similarities than differences. So the things that we've developed and others have developed with healthcare workers are highly beneficial to other folks.
Right.
And that's like kind of an element of post-traumatic growth. We learn something from taking care of them that can be useful to others going through somewhat similar situations. So we're doing a lot of, kind of consulting work and helping other organizations grow their programs, helping other organizations do meaningful research about the impact of their interventions and to adapt our offerings that we developed for healthcare workers to other settings, which has been a lot of fun, actually. We did a project with faith leaders in New York City where
Oh,
we,
cool.
in churches in Harlem, the Bronx, Brooklyn, in 2021, we got some funding from the Robin Hood Foundation. We trained faith leaders to teach their congregation about resilience. So at the end of their services on a Sunday or a Saturday, they would hold a workshop that would be broadcast on Facebook or on Zoom or in person. They'd be integrating scripture and praying together and teaching about these topics that everyone in the room needed to hear.
Right.
That was a lot of fun.
Oh, I love that. I love the collaborations and bringing people together. Well, thank you for your work and for your time today. And everyone should get your book.
Thank you for having me on.